Very good afternoon. I'm Dr. Rashi Khare, a senior intervention cardiologist from Delhi. I'm working in Fortis Hospital. Right now, I have with me Dr. Naveen, a very prominent and eminent intervention cardiologist from Jabalpur. He has got a big name there and has got special expertise in the STEMI, that means ST elevation MI cases. So, Dr. Saab, I would like to ask you first elaborate, how did you like the sessions and the working in the WinCars conference this year?
I think it was amazing to be here, and I congratulate the whole faculty and organizing team for arranging such a good conference with all women power behind it, and having so many international and national faculties of importance with so many good and current lectures in the guideline changing discussions. We have enjoyed the conference thoroughly, and I congratulate the team and hoping for the even better sessions from now onwards, annually or biannually, or whatever they plan.
Okay, so Dr. Naveen, with your special interest in these STEMI cases, would you like to let us know how important it is to be on time in STEMI cases for the patients as well, and what do you think about the pharmacoinvasive therapy?
STEMI, as you all know, is a ST elevation myocardial infarction, and is the basic pathophysiology behind it is the total occlusion of a epicardial coronary artery. And as we all know, the time is muscle, and as soon as the blood supply has to be started for the muscle to salvage the heart and EF and to decrease the long-term complications of low ejection fractions. So the earlier the better is the policy, and the class 1 indication is angiography angioplasty. If the patient can have it, it is the best treatment which we can offer to the patients having STEMI. But in certain areas where the patients are not willing or cannot reach to the hospital, or even after reaching the hospital, they are not able to make their mind what strategy to choose, then certainly these kind of patients must not be held upon in the ER for making decisions, and they should be immediately thrombolized, so that at least we can salvage at least most of the myocardium which is going to be damaged during the course of discussion. And even in COVID times also, we have seen that we have managed most of the STEMI patients with a pharmacoinvasive therapy, where we have thrombolized most of the COVID positive STEMIs, and then we have taken them for interventions, and we have found that the possibility rate of recanalization of the arteries is like 40 to 50% in these patients, and even also the thrombus burden decreases and the ease of intervention improves. So the no flow and slow flow situation is also avoided by doing a pharmacoinvasive strategy. So I think it is a very good strategy, and it should always be kept in mind when we are having a lot of time in discussions and there is no decision making from the family side.
Okay, so Dr. Naveen, one last question from you. Being in a women-centric conference right now, do you think women fare worse in STEMI, in all heart disease cases, particularly STEMI?
I think so. It is basically not because of the gender, but I think it is because of the avoidance of symptoms,
yeah,
and
denial
negligence from
mode
the
is there.
family side.
Yes.
That's what I personally feel, because women are very resilient as compared to male counterparts. So they never come up with the symptoms in time. So they might be avoiding symptoms, or maybe in few families, as we have seen, they don't want the females to be taken to the hospital in time.
Yes, absolutely right.
So my personal feeling is even if they reach in time and they tell the symptoms in time, they can be salvaged as good as their male counterparts.
Thank you, Dr. Naveen, for your words of wisdom.
Thank you so much. Thank you.